Good afternoon, everyone, and I welcome you all to this CCR on the behalf of Department of Pulmonary Critical Care Sleep Medicine. Today we will discuss an interesting case, and obviously I will not going to tell what is the diagnosis. So to discuss more about this interesting case, I call upon Dr. Soumya, who is our senior resident, who will discuss the case, and subsequently Dr. Akshay will discuss the something related to the literature and case discussion. Dr. Soumya, please.
Thank you, sir. Pardon me for my voice today. So I'm going to present the clinical combined rounds of the Department of Pulmonary Critical Care and Sleep Medicine. So we have a patient who is a 65-year-old female, resident of Delhi. She is a housewife and recently diagnosed hypertensive. She presented with the chief complaints of two lumps over the forehead for last 2 months. So coming to the history of present illness, the lumps were insidious in onset. They were gradually increasing size over 2 months, located on the forehead, slightly to the left, approximately 6 into 6 centimeter, 4 into 5 centimeter in size, and they were soft, fluctuant, and non-pulsatile, and were not associated with pain, redness, or warmth. So there is no history of trauma, there is no history of fever, no history of headache, visual disturbances, or photophobia, no history of discharge from swelling, no history of insect bites, any other systemic symptoms, and no history of loss of weight or loss of appetite in the patient. In past history, there is no history of diabetes, ATT intake, or any TB contact. There is no history of similar swellings in the past, and she was a recently diagnosed hypertension, taking medications on and off. Coming to the personal history, she was a non-smoker, non-alcoholic, vegetarian by diet, with normal diet and better habits, and there is no history of travel or any other exposure history. Coming to the family history, no similar history, no similar illness of any family members, and no other comorbidities in the family. Coming to treatment history, she presented to a local practitioner for the swelling and was treated with oral antibiotics, and there was no decrease in the size of the swelling noted. After that, she underwent a PET CT and MRI brain that was done outside. She was told to have malignancy with some lesion in the lung and brain, and was advised to undergo a biopsy from the brain. So for that, she was a bit apprehensive and presented to the Department of Pulmonary Medicine in November 2024, where she was evaluated subsequently. Coming to the examination, she was conscious related to time-recent person with stable vitals. There is right supraclavicular lymph node palpable, and bilateral basal crackles were present, and rest of the system on auscultation, and rest of the systemic examination were normal. Coming to the characteristics of the lump, there were two lumps present on the forehead, starting from 1 centimeter left lateral to the midline, 6 into 6 centimeter, 4 into 5 centimeter in size. There are fluctuant, smooth surface, and well-defined edges. They are firm in consistency, compressible, and non-pulsatile. And there were no redness or tenderness present over the lump, and lumps were not mobile and were fixed to the underlying structure. Coming to the investigations, USP guided biopsy of right supraclavicular lymph node was done outside, and with suggestive of multiple epithelioid cell granuloma with patchy areas of necrosis and Langerhans-style giant cells, and we did a EBS TBNA from mediastinal nodes that was suggestive of reactive lymphoid tissue with negative gene expert. So patient was started on ATT based on this, and simultaneously further evaluation was continued, and outside imaging were reviewed. Now I want to call upon Dr. Vishwas from Department of Radiology and Interventional Pulmonology to describe about the radiology findings.
Good afternoon, everyone. I will be presenting the imaging workup of the patient. Patient underwent 2 time point scan, first in November with the MRI brain and whole body 18 FTG PET, which was done outside. And the second imaging was done in January 2025 with MRI brain and CCT chest plus abdomen, which was done at the AIIMS. This is the MRI scan of the brain done in November 2024. It shows two well-defined lytic lesions in the frontal bone with extension into the adjacent subgaleal location. As on signal characterization, it appears to be hypo intense on T2 weighted images, and it shows diffusion restriction on diffusion weighted images. and post gadolinium T1 weighted images shows peripheral rim kind of enhancement. These lesions measured 1.9 cross 1.7, the cranial most lesion, and the caudal most lesion measure 1.2 cross 2 centimeter. Then patient underwent FDG PET, which these lesion frontal bone lesion shows FDG uptake, and also there are multiple nodules as well as consolidations along with mediastinal lymphadenopathy, which shows FDG uptake. Further imaging of the chest and abdomen will be described as follows. Patient underwent chest X-ray, which shows few reticular opacities in the bilateral lower zone lung fields, as well as there is mild blunting of the costophrenic angle, and there is a thickening of the horizontal fissure on right side, and rest of the bilateral lung parenchyma appears normal and no other abnormality. Subsequently, patient underwent CCT chest and abdomen in the January 2025, and the lung window depicts the perilymphatic nodules as well as the coalescing nodules, which are the perilymphatic nodules are better appreciated on the sagittal sections along the oblique as well as the horizontal fissure. Also, there are consolidation in the bilateral perihilar regions as well as in the basal segments of the bilateral lower lobes. These are the soft tissue window, which shows the lymph nodes in the bilateral supraclavicular region, and then in the mediastinum also in the right paratracheal region and the paraaortic region, and in the abdomen also patient had lymph nodes in the periportal region as well as in the retroperitoneum. Patient had a MRI scan done, second baseline scan, which showed the increase in the size of the lesion with similar characteristic appearance as described. And the cranial most lesion measures the 2.6 cross 4.5, whereas caudal lesion measures 1.2 cross 1.7 centimeter. So summarizing the imaging findings, there are two lytic frontal bone lesions with adjacent scalp collection, and in the chest there are perilymphatic and coalescing pulmonary nodules along with consolidations in the bilateral lungs with bilateral supraclavicular, mediastinal and abdominal lymphadenopathy. So the possible differential diagnosis on the basis of imaging are tuberculosis, sarcoidosis, fungal etiology and malignancy. So further discussion I would like to call Dr. Song.
So after clinical and radiological correlation, we kept the following as the differential diagnosis in our case: disseminated tuberculosis, malignancy, fungal infection, sarcoidosis, and lymphoma, and for which we did evaluation for. So the routine evaluation showed no anemia, no thrombocytopenia, or any cytopenias with and the HbA1c and the viral markers were normal with normal LFT and RFT for the patient. Other investigation was done, which was negative. Serum ACE levels were normal. Peripheral blood smear was normal. After that, pus was aspirated from the forehead swelling and sent for all investigation, as the patient had no improvement of symptoms after starting of ATT. So from the first gene expert was negative and cytology sensitive of inflammatory exudates. And for microbiology, I would like to call upon Dr. Angita for the diagnostic part.
Good afternoon, everyone. So I'll be covering the diagnostic part in microbiology laboratory. So in our lab, we received aspirated pus from the forehead swelling. So when we receive any sample, especially like pus sample, the routine procedure which we follow is we initially do a direct microscopy as well as we do culture of all the clinical specimens which we receive. So in direct microscopy, we perform a KOH calcaflow wet mount in fluorescence microscope, and we perform staining. Staining can be, we usually perform gram staining and any special staining if the clinician is giving us any index of suspicion regarding histoplasma. We perform an extra special stain, which is GMSA staining, and along with direct microscopy, we perform routine culture for all the clinical specimen. So we culture the clinical specimen at two different temperatures in our common media, which we use in mycology, which is agarose dextrose agar. So we incubated at two different temperatures at 25 degrees Celsius and at 37 degrees Celsius to allow the growth of fungi at either of the temperature. And also here we, since there was a suspicion of histoplasma, we had performed an extra inoculation tube, which is brain heart infusion agar, which allows better isolation of histoplasma species. So we had inoculated an extra tube, and also we do inoculation in automated blood culture bottles in case if there is suspicion. So in direct microscopy, so from the pus sample, we had performed a direct KOH calcoflow wet mount. So what we found was there were small yeast cells, 2 to 4 micrometer in size, and all of them were uniform in size and had a typical pointed appearance at one end. So this gave us an idea that this could be probably yeast, which could be histoplasma. So following our direct KOH calcoflow mount, we performed a GMSA staining. So in GMSA staining, this is the findings we found. In GMSA, we were able to see small yeast cell 2 to 4 micrometer in size, and some of the cytoplasm had retracted from the cell wall, and they have a dark purple appearing chromatin, which gives a typical crescent shaped appearance or a gradient staining, which is typical of histoplasma species. So based on our direct microscopy and special stain findings, on the first day we had communicated the report to be small yeast cells 2 to 4 micrometer in size, resembling histoplasma species. So on the same day itself, we had also inoculated the first specimen onto culture tube into subaerous dextrose agar tubes. So ideally, for the growth of histoplasma, it usually takes around 15 to 20 days, but also it might have a prolonged incubation up to 8 weeks. So we had kept that also in mind. So around up to 20 days of incubation, we were able to see this in the culture tube. We found the white cottony growth in the culture tube. And also on the same day, we had inoculated the pus sample in automatic blood culture bottle, which is Bactec bottle. So in Bactec bottle, around after 20 days, we were also able to see this fungal ball, which is also another identification feature which we find in histoplasma. So after the appearance of the growth, to identify the species and for culture confirmation, we perform LPCB mount, which is lactophenol cotton blue mount, and looking at the appearance of the fungus in the mount, we give a definitive diagnosis. So when we performed the LPCB mount, we were able to see around 7 to 10 micrometer in size macroconidia. This macroconidia has a typical appearance. It is called as tuberculate macroconidia, which has a spiny cylindrical like projections, which is suggestive of histoplasma. In young cultures, we will also be able to see small spiny microconidia. This microconidia is the infective form of the histoplasma, and microconidia will be usually seen in the young cultures. So as the culture prolonged around about 21 days, we will be able to find this tuberculate macroconidia. So tuberculate macroconidia, which is around 10 to 15 micrometer in size with cylindrical projections, was found to be suggestive of histoplasma, and we had given the culture report as histoplasma species.
So after getting a confirmed diagnosis of histoplasma, we did other diagnostic evaluation for any immunocompromised state of the patient. Urine histoplasma antigen was negative. For disseminated histoplasmosis, we did a CNS involvement, we did a MRI brain, which suggested no evidence of meningitis. Serum immunoglobulins were normal. CD4 count and primary immunodeficiency workup was also said, which came out to be normal. So final diagnosis was disseminated histoplasmosis involving bone and lung. For treatment, we started the patient on liposomal amputation B for 14 days with regular monitoring of blood parameters, and After that, she was discharged on super bioavailable itraconazole 130 mg twice a day. So on OPD follow-up, patient was doing well with decrease in size of the swelling with the therapeutic drug monitoring levels of itraconazole within normal limits. And after that, we performed a repeat CCT head, chest, and abdomen in March to look for the any radiological resolution, which will be talked by Dr. Vishwas.
The patient underwent follow-up imaging in the March 2025. As in this sagittal section, we can see there is significant decrease in the scalp and bone lesions in the frontal bone. Almost there is the lesion becomes subcentimetric, the cranial lesion, and the caudal lesion is also reduced in size. These are the chest images, which shows there is mild resolution of the lymphatic nodules as well as the coalescing nodules, and also there is mild reduction in the bilateral lower lobes consolidations, and there is a subtle decrease in the size of the mediastinal nodes also.
So coming to the review of what we have just seen right now, so this was actually granulomatous disease with mediastinal and lung involvement with cutaneous as well as bony involvement. So our differentials out here were sarcoidosis, tuberculosis, histoplasmosis, other endemic fungi, granulomatosis with polyangiitis, and chronic granulomatosis. We had systematically worked up around these lines and actually ruled out most of them and finally came up to a diagnosis of histoplasmosis. Histoplasmosis is a dimorphic fungi. Infection is likely due to inhalation of microponidia and it's a soil-based fungus, which is seen mostly along the river valleys. It has association with bird and bat fauna, and due to the presence of histoplasma capsulatum in them. And most of the cases are actually present seen in farmers in the northern and northeastern states of India, along the riverbeds of Ganges and Yamuna and the Brahmaputra. So this is the belt of histoplasmosis, which is actually seen in our country, which is in the northern and northeastern part of the country. Coming to the pathogenesis, infection is usually due to inhalation of the microponidia or the mycelial form, followed by transformation to the yeast form in the human body. Then the roles of the immune system is that there is phagocytosis by the macrophages and the neutrophils, and the bacteria, the fungus resides into the lymph nodes. And dissemination from the local lymph nodes is is via the reticuloendothelium system, which leads to a disseminated histoplasmosis. Clinical features: most of the patients are actually asymptomatic, with more than 90% of them. Among the patients who are symptomatic, pulmonary disease in its acute or chronic form is the most common way it presents. And other presentations could be mediastinal lymphadenitis, mediastinal fibrosis, pericarditis, some rheumatological and skill manifestations. And disseminated histoplasmosis is actually very rare, seen only less than 1% of our cases. Coming to the pulmonary disease, as we can see, the acute presentation of histoplasmosis can actually present as just like a bacterial pneumonia with bilateral diffuse patchy opacities with enlarged lymph nodes, and it can have actually present as severe capillaries as well. In the subacute form, is actually having milder symptoms with similar CT findings. Come to the nodular find, as you can see, there's a peripheral nodule which is there. It is a pleural-based nodule which can be seen, and it is usually asymptomatic in most of the patients, and these patients do not require any treatment. In the chronic cavitatory form, the CT usually presents like a cavitation with fibrosis and some amount of pleural thickening, and most of these patients require treatment for a prolonged duration of time with high chances of relapses in these cases as well. Come to the extrapulmonary involvement in disseminated histoplasmosis. As we said, that disseminated histoplasmosis itself is rare. Amongst that, the common presentation that are hepatosplenomegaly, lymphadenopathy. The reticuloendothelium system is the first to get involved, followed by adrenal involvement, which is seen in about 10% of the cases. Skin lesions with papules, nodules, as ulcers can be seen in around 5% of our patients. Pericarditis is also seen in some rare patients. This is mainly due to the mediastinal involvement itself. Bone involvement, which is seen in our case, is actually very rare. It is seen only in a selected few case reports, which are less than 10 as per current literature available. GIT involvement is also rare, and CNS involvement usually presents as chronic meningitis in around 5 to 20% cases in different literature. Coming to some case series of histoplasma involving the bone as well as the lungs. So these are 3 cases that we have seen previously. These are all pediatric patients who are having histoplasmosis, which was diagnosed, and all of them actually were treated as with a prolonged duration of treatment for around 6 weeks to around 1 year with either amphotericin B or itraconazole with symptomatic improvement and a good follow-up. Amongst disseminated histoplasmosis, it can also present in acute, subacute, or a chronic form. Depending on the symptoms involved and depending on the presentation, it is usually presents as hepatosplenomegaly or lymphadenopathy in the acute form, and specific GI involvement, specific involvement of organs like the adrenal, which present as adrenal insufficiency. The subacute form and the chronic form also presents a similar way. In the chronic form, chronic meningitis is relatively a common presentation. The diagnosis is established by histopathology or microscopy, fungal culture, serology, or antigen detection. I'll just come to the details on the next slide. Usually, in progressive disseminated histoplasmosis, the sensitivity of each of them is as respected. With the antigen detection, this can be done in the serum as well as in the blood and as well as in bile samples, with being around 92%. The antibody detection is around 75%, with pathology and culture contributing 76% and 74% respectively. Serum galactica phenomenon can also give false positive cases in histoplasmosis, and therefore it is not useful for diagnosis. The management usually is guided by two main antifungals, which is amphotericin B and itraconazole, and imaging helps us to further guide the diagnosis, as we will be able to decide whether there is isolated pulmonary involvement or whether there is dissemination. The severity of acute pulmonary histoplasmosis can be divided into three types, which is mild, moderate, and severe. Mild patients are usually those with symptoms which do not interfere with the normal activities. Moderate are those which are having symptoms which would be affecting their normal activities or having low flow oxygen supplementation and may require hospitalization. Severe patients are usually those patients with severe respiratory failure requiring hospitalization, and subsequent mechanical ventilation also may be required. In severe cases which present as ARDS, methylprednisolone has also been tried in the initial days for the ARDS presentation. In cases of acute pulmonary disease, which can be either mild to moderate, usually itraconazole or no treatment can be decided in some cases. This is usually decided based on the immunological status of the patient itself. In moderate to severe patients, liposomal amphotericin B followed by itraconazole should be given for around 6 to 12 weeks. Our patients which are presented with progressive disseminated histoplasmosis, this was in mild to moderate patients, it should be treated with 12 months of itraconazole, which is given at 200 mg twice a day dosing with therapeutic drug monitoring of itraconazole. And in severe cases, the initial 2 weeks is treated by 3 to 5 mg of liposomal amphotericin B, followed by prolonged duration of treatment with itraconazole around 200 mg PD for 12 months. Other causes where CNS histoplasmosis can be presenting, here the dose of amphotericin B is actually increased to around 5 mg per kg, and the duration as well is increased to 4 to 6 weeks, and also followed by treatment with itraconazole for around 12 months. Coming to histoplasma endocarditis, it usually requires a surgical valve removal as well as liposomal amphotericin B, which are for a prolonged duration of time till culture negativity. Mediastinal lymphadenitis and granulomas are treated with only when there are symptoms are present in these patients with itraconazole, and usually presentation of solitary pulmonary nodule or mediastinal fibrosis or bronchiolithiasis do not require any treatment. Take-home points will be that the histoplasmosis is a relatively rare disease and it should be suspected in patients with granulomatous disorder. Majority of the patients are asymptomatic, with lung being the most common site of involvement. Presentation of a lytic bone lesion is actually very rare, which is our patient in this case, and most of these are misdiagnosed as TB or malignancy. Treatment of the disease varies as per different spectrum of the disease. I would like to thank the Department of Microbiology and the Department of Radiodiagnosis, Interventional Radiology, and for their help. Thank you. I'd like to call upon Dr. for further discussion on it.
Thank you. Actually, there are 2-3 things which were relevant in this case. When this lady first came to my OPD, she has a big lump over forehead. At least 2 lumps were there, and I was wondering why she has landed up with me. So first I thought, why not to refer her surgery OPD? Maybe they are good to assess the lump, what is the nature, and how to proceed for biopsy. But subsequently, she told me that she had already undergone a biopsy from the lymph node in the supraclavicular lesion that was showing multiple granulomas. And then I gone through the reports, and the PET scan was highly suggestive of malignancy because these are hot lesions, multiple sites. And as a pulmonologist, we always think that lung lesion, multiple lytic lesion, it is malignancy. So in that way, she came to me, and she was told in outside that because your lymph node biopsy is not revealing any diagnosis, we need a biopsy from this scalp lesion. And she was told that it's probably extended to the brain, so it may cause some problem with the brain. So that's why she came to us. And subsequently, once the things evolved, then we reached the diagnosis. The important thing is, as a pulmonologist, we always feel a problem. When we don't suspect granuloma, they will be there, and when we want, they will not be there. So that is a common problem. So initially, I thought this granulomatous lesion, what I have shown, maybe false sarcoid-like reaction, which is very common among many conditions. So now the house is open for the discussion or any question. I will be happy to respond. Sir.
But once the diagnosis is made for different response, somebody says we can only say where now all the people medicine was still they are doing asking for the diagnosis in our inside. If you are not finding anything, then who was. This then the time where we should other most common you don't have this common or
I absolutely agree with you. That's why we did not stop there unless we proved the diagnosis by biopsy or sampling. And this is the usual protocol.
the report this needs to
Actually, very interesting case. This case actually we got the ambulance negative. Probably, maybe, I don't know whether and how the patients have get the sample because we need to take us fasting. So that's not good reason. And another thing is like what we are using that kit. Maybe that's actually not API. API actually we want to it and Miravista. This right now actually we don't have it. Miravista is not selling. Only US people can. Another kit we can buy that one. And what we are using is network flow. That's maybe that's in case actually ranges quite from 60% to 80% back. So maybe we can pick up. And maybe that some preparation is very important.
Thank you, ma'am. This I was not aware that urine sample for rectoplasma is and are in 38 hours. I don't know whether this was followed or not.
the residents should know that the patient has probably fluids just concentrate in but this is a so concentrate in the sample also has to concentrate babies but the delays at home.
Okay, I think that can be a learning lesson for residents who are ordering this test. I hope that this precaution are taken before sending samples. Dr. Priyanka, you want to add anything?
What happened that for the reaction more than the
Yeah. Okay. So once,
involvement is
yeah.
who represented who integrated or not.
So actually, once she came with this the cervical lymph node biopsy, which is showing granulomas, to avoid this biopsy from this lesion in the scalp, we did EBUS also, but that showed only reactive lymph nodes. And I also agree with you that probably she is having underlying sarcod also. Initially, I thought this lesion and there is lymphangitis probably, because I was thinking it's lung cancer and then metastasis. I don't know. Maybe as the disease will evolve, then we will come to know whether this whole histoplasmosis, or there is some sarcoid element is also there.
Question for Dr. Bal. Basically, like you rightly said, and the modality for localizing the active problem and for a biopsy. So, are you still doing better biopsy more over some problem that will be done? So, will it be done better? So, I mean, so maybe like a collapse. They collapse, and there is a lesion that also. So, or maybe anywhere. So, there is a big lesion, but the half part is a small part. But when we said
Thank you everyone for good discussion, and